presentation is brought to you by Therapeutic Articulations, the creator of the Mobil-Aider orthopedic device and iOrtho mobile app. This presentation is about joint mobilizations. Mobilizations are the skilled passive movement to a joint directed towards restoring accessory, also known as arthrokinematic motion. The concave convex rule is our guiding principle for joint mobilizations. When convex is moved on concave, the direction of joint glide is opposite of the direction of osteokinematic motion. Whereas when a concave surface is moved on convex, the direction of joint glide is in the same direction of osteokinematic motion. The indications for joint mobilizations include improving accessory or physiologic motion, restoring normal articular relationships, symptom relief and pain control, enhancing motor function, and reducing muscle guarding. Of course, there are absolute contraindications to joint mobilizations, and they include a host of items identified on this slide. In addition, there are precautions that should be adhered to when performing joint mobilizations. And these precautions are identified on this slide. The movement impairment algorithm begins with an examination of the joint, and then the answering of several questions. Is the sign reproducible? In other words, what are the cause of the symptoms? What is the region of origin? Where are the symptoms? And how reactive or symptomatic is the individual? Based on the answers to those questions, you may determine that this is an instability syndrome, which needs stabilization exercises, or this is a hypermobility syndrome, which needs joint mobilization. If the answer is that joint mobilization is needed, then you need to decide what grade. Are you looking to impact the neurophysiologic aspects with joint mobilization? In other words, the firing of articular mechanoreceptors and proprioceptors, the firing of cutaneous and muscular receptors, or the alteration of nociception. Those will be performed with grades 1 and grades 2. However, if you're looking for the mechanical effects, such as stretching of joint restrictions, breaking of adhesions, altering positional relationships, or diminishing or eliminating barriers to normal motion, then you would want to perform grade 3 or grade 4 mobilization techniques. Now, please remember that these techniques are not linear. You don't need to begin with a grade 1 and then progress to a grade 2, 3, or 4. You can start with a grade 2 or 3 to address the neurophysiologic effects, and then jump right to a grade 4 to embrace the mechanical effects, or vice versa, right? Create a mechanical effect with a grade 4, and then go back and address or alter the nociception with a grade 1 or 2, right? So there is not a linear relationship with these grades of joint mobilization. That being said, a joint mobilization should begin with a distraction technique. This is a perpendicular movement to the treatment plane. This separates the joint surfaces and makes joint mobilizations much more comfortable. So you should perform a distraction prior to performing a joint glide. The joint glides, as described by Maitland, are based on the elements of tissue resistance. A grade 1 is a motion that's of small amplitude in the beginning of the range, whereas a grade 2 is a larger amplitude within the range but not reaching the tissue resistance. A grade 3 is a larger amplitude up to the limit of range, and a grade 4 is a smaller amplitude at the limit of the range. However, we can know these rules about joint mobilizations and we can appreciate what each of these grades are But the psychomotor skills are a whole different element. And this presents a clinical problem. The clinical application of mobilization techniques has been reported to be quite variable. And this lack of consistency can have a significant effect on patient recovery. There are also significant challenges in learning joint mobilization techniques, and the novice clinician could benefit from quantitative, real-time feedback to assist them in learning these techniques. This is where the Mobil-Aider enters. This is a lightweight, portable, cost-effective device that provides real-time visual feedback in the performance of joint mobility. The deluxe version of the Mobil-Aider has 7 attachments for 5 joints to perform over 14 different mobilization techniques. In the A mode, this is a setting on the device, this enables you to assess the end feel. This holds the max value of that linear translation for you to be able to read what the actual mobility of that joint is, or in some cases what the limitation is. The B mode is a real-time measurement that allows you to appreciate where you are in the continuum of that mobility. So here's a video displaying the A and the B modes. Here you see in the A mode how the device holds the max reading for 3 seconds, resets, and then allows you to see it again. In the B mode, this gives you real-time measures of where you are in the motion, in that linear translation. So it allows you to make sure that you are in the decided range for a given joint mobility. In other words, if a joint has 8 millimeters of motion and you want to perform a grade 4 mobilization technique, then you want to get to that end range, which is 8 millimeters, but you want to perform a small oscillation, perhaps in the 6.5 or 7 to 8 millimeters of motion. So small amplitude at the end of range will assure that you are doing a grade 4 joint mobilization. Here you see the device on a knee model that enables you to see exactly how this works. So this is giving you the measurement, the real-time measurement in the A mode. And now you know what the end feel was. And now you can pick your grade and stay within that defined grade with real-time measures within tenths of a millimeter to ensure that you're performing a consistent treatment. In addition, the Mobil-Aider can help you when you're performing a technique incorrectly. For example, if here you want to perform a wrist mobilization, but you're not at the joint line, you can see that the device doesn't read anything. Okay, it's not moving because you're not performing the mobilization correctly. Line the device up appropriately with the joint line, and now you can actually see the real-time linear translation. In addition, think about the novice clinician learning these techniques, right? The idea that they don't know what a capsular end feel feels like. And the clinician is going to have a really difficult time explaining that to them unless they actually feel it. So giving them a device and saying to them, can you feel the capsular end feel at 6 millimeters? They know when they press to 6 millimeters, they're actually getting to that capsular end feel, and they can begin to feel that creep at 6 millimeters to know that that's the end of the range for that person, and that's what a capsular end feel feels like. It greatly improves the consistency of the techniques. Finally, when you speak to performing these techniques, every joint mobilization intervention should begin with a trial technique of 1 to 5 repetitions. And then it should be determined, how did those 1 to 5 repetitions impact the patient? If there was no change, then increase one variable and repeat another 1 to 5 repetitions. If they were worse, decrease one variable and repeat 1 to 5 repetitions. If they are better by a slight amount, then keep everything the same, but repeat the 1 to 5 reps. If they're much better, then hold and monitor. And then by all means, regardless of what happens, always re-examine after every joint mobilization treatment. If you'd like more information about the Mobil-Aider, please visit the website iortho.xyz, where you'll find joint-specific videos for how to use the Mobil-Aider and how to perform joint mobilization, as well as how to assess the ACL with the Mobil-Aider. Thank you.